We're so pleased to have our next speaker, who's an expert in not only physical therapy and training and lymphedema, but is also very dedicated to health policy and helping to move the legislation and payment forward in this field. Nicole Stout is a consultant to research and health policy. She's on the board of the American Physical Therapy Association. She's a founding member of the American Lymphedema Framework Project and has served in recent past on NLN and LANA as well. So she's well connected in our field and is helping to really move things forward with the prospective surveillance research that she's done, as well as in health policy. She comes to us today from Bethesda, Maryland, and we're just so honored to have her with us. I'll turn things over to her now. Thank you, Nicole.
Thank you. Thanks, Jane, and the ALFP Steering Committee for having me here. It's always so fun to come and see all my friends again. And, you know, I've heard the speakers this morning and how phenomenal their perspectives are. And talking with all of you and with some new faces in the room, you know, what I hear again and again is how dedicated this field is to the patient, how much that matters to all of us. And it's very heartening to be in a room that, you know, we all know one another. It's a friendly environment, and we have such great resources that we're building towards enabling better care for our patients. So I'm going to talk to you this morning about cost and economic considerations in lymphedema management. And this comes on the heels of a publication that you may or may not have seen, which was published in Lymphology last year, and that was the ALFP's systematic review on economic considerations. And I was the lead author on that with Bob Weiss, who's not here in the room with us today. But what I want you to do today is my goal is going to be to get you to think a little bit differently about what this means, what economic considerations mean. I think when we say economics, a lot of people think of cost, right? You think, how much am I going to get paid? How much is it going to cost my patient? How many dollars does a therapy session equal? And what I want you to think about today is that economic considerations encompass so much more than just cost. And so when we frame that in the context of talking about lymphedema and lymphedema management, one of the buzzwords, things that we're seeing rise to the surface in healthcare these days, is really all about value. What is the value that we provide through our services? So cost is a part of that value equation, but the quality of the service that we provide is equally, if not more important, aspect of that part of the equation. So cost is important. It has to be reasonable in cost, but the value really comes when we show that that cost is associated with a high quality product. So I was just talking to someone out in the hallway and I said, the pie is not going to get any bigger, right? People don't want to spend more of our GDP on medicine and on healthcare. What we need to do is demonstrate our value so that we can express why we need a little bit of a bigger piece of that pie, why it is beneficial for our patients or will be beneficial for our patients if more therapy services, compression garments, etc., are covered in a way that is more appropriate to the care that we provide. So what I want to do today is talk a little bit about what we know so far in the field of lymphedema, what has been published and what data we have that can help us better understand how we can portray our value. So how do we analyze that? There are a lot of different ways to look at the economics. And unfortunately, when we think of basic 101 economics, we think of supply and demand, right? And that's all skewed in healthcare because we really have a poor understanding of what the actual supply of healthcare services looks like and the demand that patients are experiencing. And we tend to look at that in silos, within disease state, et cetera. We also need to look at the cost. So we can look at cost comparisons and say, what does it cost to treat in an episode of care? What does it cost for a garment or a pneumatic compression pump? We could take that a step further, though, and we can look at a cost and benefit analysis. So what does it cost us to get a benefit out of using those pieces that cost dollars? How do we put that together and show that there's a benefit to what we've done? Not only do we need to say what is the benefit, but What measurable outcome can we use to show us that we have achieved something that is beneficial? And I'm going to carry the gauntlet today and say it's not enough. It's not enough for us to just say we've reduced your volume by 80% and that's a good outcome. That may be a very stinky outcome if our patient cannot get back to work, if our patient is still disabled, if our patient's quality of life suffers in the self-management techniques that we give to them and constrain their lifestyle. So there's more to understanding the cost and the value when we bring the patient into the mix. And that's what these cost-effective and utility analyses really help us get at. We're not there in the world of lymphedema in looking at more sophisticated comparative effectiveness and cost-utility analysis. But after today, I hope to give you hope. We have the tools available to help us move in this direction. We have the resources available, and I think that in the future we can see a better profile created of what our value is based on our cost and comparative effectiveness of what we do, showing benefit. When we think about perspectives on cost, again, whoops. That was a wardrobe malfunction. Not a bad one, not a Janet Jackson wardrobe malfunction, just a little one. So when we think of perspectives on cost, we also have to think of it very broadly. We have to take a broad brush. Again, if we look at the cost of what does a garment cost, or what does it cost for an episode of care, we're looking at that from a very narrow perspective. We have to think a little bit broader than that. How do we justify the use of a garment? I'm telling my insurance company, you need to spend more money on using a garment. Well, how does that contribute to improving the chronic management of lymphedema? Do we reduce the number of hospitalizations related to infections if we give patients better standardized care and we give them better tools and devices to manage their care? If we pay more for compression garments, if we get Medicare to cover compression garments, will we be able to demonstrate positive, meaningful outcomes that impact the costs associated with these very expensive associated issues? The societal cost also needs to be considered, right? What happens to a family of 4 when one of the people in the family develop lymphedema and now suddenly they can't go to work? That family has to shift resources. The business that person used to work for now is covering them for disability. So there's a shift in resources there from a societal perspective that we need to think about how we can impact by demonstrating value in our services. A lot of what we've seen, and I'll talk to you about today, in our literature base has been in direct costs. We've looked at the cost of that thing, but we also need to think about a perspective of the indirect costs. So the lost years of quality of life, and what are the costs associated with the secondary things that happen because of a lymphedema diagnosis. So we have a number of problems in the field of lymphedema management when we try to look at the true economics of where is the value and what is the benefit that we offer by providing therapy services. The costs are relatively unknown. We don't have a lot of reported information in the literature. Getting cost data, why is that? Getting cost data is cost prohibitive. It's expensive to get Medicare database access. It's expensive to get Avalier to run an analysis for you on a data set. It's expensive to get claims data. We also struggle, and this is not unique to lymphedema, this is across medicine, we struggle looking at the actual cost of service. What does it cost? Because your therapist bills a certain amount of money, and the insurance company pays them a different amount of money. How much does the patient have in a copay? How much do they pay out of pocket? Do they have an annual amount that they need to meet before their insurance kicks in? So there are a number of other costs that we have to consider that are not just what does it cost in an episode of care. And then there are the equipment costs. Another problem that we face in truly understanding the economics is the epidemiology of lymphedema. We really don't have
a very good perspective on what the epidemiology is of lymphedema. Dr. Roxon and his colleague did what I would consider a Herculean effort in putting together a review of quantifying epidemiology within disease state in 2008, a publication that was very nicely done. But it was cancer-specific and non-cancers as well, broken down by disease state. We do see in developing countries the lymphatic filariasis many times quantified geographically. So number of people per million in or per 100,000 in Burkina Faso or in Ghana with lymphedema. So there's disparity in the way that these data are portrayed, and that makes it challenging for us to quantify and conduct economic analyses. And the outcomes that we traditionally utilize are poorly defined and are disparately measured, quite honestly. Is volume a good proxy for a positive outcome? I don't know. I truly don't know. If my patient's volume decreases by 10%, but they're exceedingly excited and their quality of life is better and they are able to re-engage in society, that's a good outcome, isn't it? So how do we demonstrate a meaningful outcome that's clinically meaningful, but also meaningful to the patient? So we've got a lot of issues, but let's talk about what we do know and how we can look to the future to build on the information that we have now to help us better understand how we can facilitate better care. So what we do know, we know the World Health Organization just about 2 weeks ago released their World Cancer Report. They do that report about every 5 years, and it was just released. And we know that there is a rise, an anticipated rise in the rate of cancer over the next 2 decades. And this is associated not so much with an increase in the population burden. This is more so associated with an aging population. Cancer is a disease of age and progresses as such. We know lymphedema is highly associated with cancer, so we need to be concerned about this. The aging of our population and the rising cancer rates are going to put a greater burden on our services. We also know that the economic burden of cancer morbidity is significant. Worldwide, it has been identified as the #1 economic burden placed on societies. It costs more to treat the morbidity related to cancer treatment than it does to treat morbidity associated with heart disease, with HIV and AIDS. It costs more to treat morbidity in cancer than it does to treat morbidity with tuberculosis. So worldwide, this is, again, the morbidity cost. This is not the cost of chemo and surgery and radiation. This is the cost of the lost quality years of life. It's the direct cost of repeat visits because of the late effects of cancer treatment. And a big part of that, as we know, is lymphedema. What else do we know? We know that cost comparisons have been conducted. Tina Shih did a very nice article that was published in JCO. As I go through my slides, you'll see the names of the authors, and then I hope you have access to the slides at some point because the last few slides are the references, so you can access those. And I'm happy to send them to you if you don't have access to them in a way through ALFP. So the cost comparisons have been done. A cost comparison was done looking at patients with and without lymphedema. This was in a breast cancer cohort. So this was based on claims data. So an insurance company says, here's what we paid in claims that were submitted for patients who had lymphedema associated with breast cancer. And Dr. Shih compared that over a period of time to a breast cancer cohort claims of patients that did not have lymphedema. And she found that the cancer patients with lymphedema incurred greater medical costs. So we know that patients who have lymphedema associated with cancer experience greater medical costs. Is that attributable to the lymphedema? We don't know. Right? The claims don't tell us that story. The patient chart may tell us that story. The CPT codes may tell us that story, but the claims data doesn't. So she did identify there are greater costs associated with, in this population, they had more infections. They had more imaging tests conducted and more prescription medications. So those escalated the cost. The question is, did the patients have a more severe state of disease that was attributable to an increase in cost escalation? So what do we know from this? We know that patients who have lymphedema related to breast cancer incur greater medical costs. Other cost comparisons have been done, treating lymphedema using a prospective model versus comparing it to the cost of treating traditional lymphedema, stage 2 or stage 3 using CDT. What does this tell us? It tells us here's the cost dollars in direct costs. Here's what it costs to treat a patient using a prospective model of care. We've talked about using prospective surveillance for early identification of lymphedema. And the theory behind that is if we catch it early, it is in a less severe state and may require less intensive treatment. If we wait until the patient has a presentation of stage 2 or later, they require more intensive treatment. So we make assumptions and say treating every patient with prospective surveillance carries a cost. So the comparison, though, is that if we identify patients early, again, based on incidence rates in the literature, that the cost of treating with a prospective surveillance model may offer some level of cost savings. What we don't know from this is the overall cost of prospective surveillance beyond breast cancer. This was modeled on incidence rates. We don't know if there is further potential for these patients who are managed with this cost to go on and develop lymphedema down the line. We know that lymphedema is a progressive condition if it's not managed appropriately, or can be progressive with infection or other considerations. So there may be additional cost that these patients incur if the condition progresses. But what do we know from this? We know it may help to reduce the cost if we're able to identify patients in an early stage of lymphedema and manage them proactively rather than waiting for patients to develop a more progressed stage of lymphedema. Now, one of the issues that's consistently brought up with this work is well, we have to put out, your insurance company says, prevention is all well and good, Nicole, but it's going to cost me money in the short term, and it's not going to benefit me until maybe years down the line, maybe. So my insurance company is concerned about their risk pool today. Okay, within the next year, that risk pool is going to change. So the money that they put out today does not necessarily benefit that risk pool, that same group of people. So they're paying for health and wellness in a group of people that may not be their people in a year or in 5 years or in 10 years. So we're relying on their nature, their good nature, to say that it's worth them putting out this money to prospectively evaluate patients in a preventive manner and take those dollars out of their pocket. Why should they do that? What's the value that this model of care brings? What else do we know? The systematic review that we published demonstrated that there are various models of care delivery that are effective. So we know that there are educational models that are effective in helping patients identify lymphedema at the community level. Community-based risk reduction, school-based models in developing countries. Group classes are effective at educating providers to improve identification, early identification, but also just overall awareness of the condition. So models of education are effective as a care delivery model. We also know that there are clinical intervention models like CDT, using multimodality interventions, clinical intervention models like nurse-led community care models, such as those used in many developing countries where we actually have community-based providers who go into the homes and help patients to maintain their condition. We know that these clinical intervention models are effective. We also know that the model of care delivery and the system of care have cost implications. It matters if we ask the patient to come in for a visit every 3 months. It costs money. It also takes away from what the patient is doing in their life from day to day, right? They have to take a half a day off of work to come in for a visit. They have to pay for parking. They have to pay for gas. So we know that the model of care delivery and the system of care have an impact. We know that educational interventions have an impact. The measurement techniques that we choose have an impact. What is the value of having a $20,000 piece of equipment in your clinic to measure your patients? Does it make you more effective in your utilization of time? Does it make you more efficient? Does it make you more effective in identifying lymphedema at an early stage? So there are considerations, and we know that the model that we choose, the system that we choose, has an impact. We also know that chronic condition management can be impacted by the care delivery model. We know implementing decongestive therapy can help to reduce infection rates, reduce the use of antibiotics. Hospitalization rates have been shown to be reduced in a cohort with recurrent cellulitis. These two studies, however, give us a glean of the potential for that better improvement in chronic care management. However, the Lynch study was a case study of one patient. So before, after looking at them over a period of time, decongestive therapy helped to improve the rate of recurrent infections in this patient. That's important for us to know, but we need more data. The Arsenault study demonstrated hospitalization rates reduced in a cohort of patients over a period of time after receiving decongestive therapy. So there was a look-back period at their infection rates, and they followed them forward after decongestive therapy and found reduced hospitalization rates. That's where we can show value. Again, a very, very small N. But these are the kinds of things that as you walk out of the room today, hopefully will trigger your thought processes as to what data can we collect to help us improve that value proposition. What do we bring to the table? Data like these, when magnified looking at a cohort of patients, let's say 10,000 patients over a period of 5 years, can really demonstrate the value of decongestive therapy if we can show a reduction in the expenses associated with chronic condition management. The other piece of this is the patient piece and the quality of life piece. And we don't fully understand, we haven't fully portrayed how our interventions impact our patients' quality of life. Andrea Cheville has published what I believe is the first, and up until this point, I still think the only study that has looked at utility values. Utility values help us to better understand the patient's quality of life associated with a medical condition. So utility is a number from 0 to 1, 0 being very bad and 1 being perfect health. And the patient verbally portrays where they fall along that continuum. However, it's analyzed in a very sophisticated way to give us an understanding of what impact having lymphedema has on a patient's quality of life. So we have utility values which are useful in us building on that, using that as a building block, better identifying quality of life years for patients so that we can better understand the cost associated with a year of life in a patient who has lymphedema. How does therapy improve that over time? We also know that outcomes measurements are quite disparate among therapists. We can't rely on limb volume anymore as our only proxy for an outcome measure. And Medicare functional limitation reporting has really driven us in a direction of identifying more comprehensive outcomes measurements. These can be performance-based measures, but the preference really is that they be patient-reported measures of outcome. The Physical Therapy Association has undertaken an endeavor to develop a database, an evidence database that can guide practice, has conducted systematic reviews in looking at different topic areas and identifying the tools that have the highest amount of support in the literature to be recommended as useful in with the breast cancer population in quantifying function and quality of life. So on a scale of up to 5, the different tools that were identified in their systematic review. They recommend the use of the FACT-B+4 and the DASH. Lymphedema measurement techniques were also looked at with a recent review in the EDGE task force. Again, this is breast cancer specific. They found the highest recommendations with circumferential measurement, with water displacement, and with bioimpedance spectroscopy. Both of these articles were just published in the most recent January issue of Rehab Oncology, the Journal of the American Physical Therapy Association Oncology section. Some of the other recommendations, we were not able to make a recommendation at this time, and usually this is not because it's not a good tool, there's just not enough data to support clinical utility in the tools. So what else do we know? We know some conceptual and theoretical things. We know that healthcare economics are driving policy changes right now. We know that cost considerations and economics are at the forefront of what is leading to change or has led to change with many of the ACA mandates, the High-Tech Act, and the changes that we're seeing at a federal level. We also know that we have to consider the cost and the value of what we bring to the table, and that there are many aspects of cost, clinical effectiveness, and outcomes that we've started to investigate those in our field, but that there are a lot of gaps that remain. So I guess one of the questions that I'd like to leave you in thinking about is, how do we define value in lymphedema therapy services? Value is not just about a cheap intervention. Value is about a good intervention that gives us a good outcome that's meaningful to our patient. Value is also about something that's meaningful to the patient. And that may be a cheap or an expensive intervention, but if it improves their quality of life and it improves patient adherence and can reduce other indirect costs, that's a good intervention. How do we identify value? What is our value proposition? And if we think of the continuum of healthcare, we think of value-based healthcare. How do we find and identify what gets us at value-based healthcare? It's many of the things that ALFP has started down the pathway of doing. And I'm going to make some recommendations here on how we would continue to do those things in the future. And hopefully that will contribute to some of the thoughts in our discussion this afternoon with strategic planning. The value proposition, we get value by identifying best practices in care, reducing variation in practice based on those practice guidelines in best care, by encouraging providers to adopt the best practice. So it's great to have a best practice document and say, here's the evidence behind the best practice. But if 60% of our therapy community is not implementing, our variance is all over the place. We don't know if we're getting good outcomes or what those outcomes are based on. And costs are all over the place. And patients are saying, what? I went to this therapist and they did this thing, and then I went to this therapist and they didn't rub anything, and then I went to this therapist and they did. That's a problem as well, because then our consumer doesn't know what's good care or what's meaningful. So identifying best practices and encouraging their adoption. Measuring provider performance. So the utilization of outcomes over time and in a course of clinical care. Measuring how our therapists change their performance by using practice guidelines. Cost effectiveness also can help us to contribute to demonstrating value, and then using all of those to help us inform policy development and implementation so that we can emphasize how that value will translate to improving overall value in healthcare. So in identification of best practices, what have we done? Here's where we are. Creation of best practice guidelines, identifying clinical models, and utilization of RCTs and cohort studies. We need to move from here to the next step. The next steps are promoting these high-value, effective care delivery models. What's wrong with utilizing home-based and community-based tools and interventions? I would suggest there are a number of people in the room who are using technology or who are developing technology that will help to enable us in finding better value, not bringing these patients in every 3 months or, every year even, if the patient's able to use an index from their home computer. Data contributions to a national registry need to happen. Commenting on Shirin's wonderful talk, and Polly, you hit it right on the head. I think it's a lot to get heads around, but that is the future of what will help us to define best practice and what will help us to define our value. Because an outcomes registry like that will help us identify cost. It'll also help us identify those trends in utilization and variation in utilization. So the future of our data collection is in that national registry. And we also need to move to encouraging the use of valid outcomes. I think it would be a very bold statement and a very strong statement for the ALFP to come forward and suggest recommended outcomes measures. There are about 30 or more outcomes tools that are utilized in upper extremity breast cancer lymphedema. There are a number that are used in lower extremity lymphedema. and the number in head and neck. What are the best tools? How do we identify and distill down the validity of those tools and make recommendations as to what are optimal tools to identify outcomes? Adoptions of best practice, I think defining a standard of care we have done. I would encourage researchers and us to put forward a research agenda that helps us to move away from promulgating these equivalency studies of treatment techniques. We need to get beyond that. We have clinical efficacy studies that demonstrate to us that CDT as a multimodal intervention is good. We know that pneumatic compression pumps can contribute to that. We should be to a point where we move beyond just saying these two interventions are equivalent. Who cares? What does it mean to my patient? What does it mean to cost? What does it mean to the outcomes that we can achieve by implementing those interventions? How do we get at that? That's the translational research piece. That's the comparative effectiveness piece. It's not just looking at clinical effectiveness. It's also looking at the overall outcomes. It's also including a perspective on cost. So comparing an intervention to lack of intervention is one aspect of a randomized controlled trial, but moving that to really understanding the comparative effectiveness is a next step. Provider performance measurement, we have done an excellent job of identifying and defining a level of education for our providers, but the next step that we need to encourage is to move them to participate in national registries. We need to move them to participate in some of the quality reporting mandates that exist now. How many therapists are participating in the physician quality reporting system, PQRS? Many of those measures are very applicable to our population. If we begin reporting, and we encourage that, if we participate in the National Quality Forum, we're able to identify measures that are more relevant to our community and encourage participation among our therapists. Adopting health information technology is something for us to encourage, and that's using data, as Shirin showed us, in the form of dashboards to help in real time to inform clinical practice. It's better understanding our patient's profile and predictive analytics to help us understand how they will respond to treatment. We also need to move our therapists to assessing outcomes measurements and being able to distinguish quality between providers. This is a little bit of a sticky situation, but benchmarking is important. And it's not about pointing a finger at a therapist and saying, you do it right and you do it wrong. There was NPR just ran a study yesterday, and it said most physicians think that it's everyone else who's doing the wrong care and the variation in care. And I would suggest many times our therapists don't realize how much they deviate, right? It's a whisper down the lane a bit. And utilizing benchmarking data could help them with reporting to bring them back into that standardized treatment template as opposed to them being the deviant or variation in practice. Cost effectiveness, we've captured some direct costs. We've done some work in cost comparisons. In order for us to make that meaningful, we need to look at what are meaningful outcomes for our patients and analyze the relationship between those costs and the meaningful outcomes. That's where we demonstrate our value. We need to look at the total economic burden of lymphedema, improving our epidemiology efforts, being able to better quantify where these patients are, who the patients are. Efforts through registry data will help us achieve that as well. We also must better quantify indirect costs and do cost modeling, helping us to better understand the impact on chronic disease burden. All of these things will come together to help us to move towards being proactive in policy. We react now, right? Medicare just released their suggested rule for hospitals. They just released the new suggested rule for inpatient rehab facilities and SNFs. They're suggesting a 2% increase in reimbursement for rehab facilities, inpatient, and for SNFs. They're suggesting a significant decrease in reimbursement rates for hospital-based clinics. How do we get ahead of that? How are we on the cutting edge of that? So providing data that we can garnish from a registry, providing data that we can portray as value added, that's going to help us to drive policy. So what is our value proposition? Well, we want to improve access to quality services and lower cost while requiring greater accountability on the part of all stakeholders within the healthcare system. That's a general definition. I didn't make that up. This is a definition from a value paper that was written, and you have the reference by a colleague of mine, Dion Jewell. It relies on stakeholder accountability to implement best practices. That's not just the therapy community. That's providers, also that is health reimbursement insurance companies saying this is best practice and you will comply, right? We also need to look at how we reduce the variation in practice. We need to improve the patient experience, reduce costs, and improve the health of the population. That's the triple aim, right? That's the triple aim. That's what ACA is based on. That's what all of the mandates are supposed to be getting us to. Improving the patient experience, reducing cost in healthcare, and improving the health of the population. How do we do that? What is the value that we bring as lymphedema therapy community? So I'm a few minutes over, and I'm sure that I think Jane will have, I do maybe have a minute or two for questions. Yeah.
My experience in trying to talk to CMS about funding garments for lymphedema treatment basically boiled down to denial based on lack of evidence and efficacy for CDT. So I would argue that we have not made a good enough effort. They went through and did a Cochrane review and found that there are only 3 studies that stood up to scrutiny in terms of supporting the use of CDT. So unfortunately, even though we are in the trenches, we see it every day, we know that it's valuable and it works, there is not compelling evidence in the literature showing what we do every day for lymphedema treatment is effective. It has not convinced the payors to pay. So we actually have to go back and do that research in addition to all of the other things that you have presented and are important.
Well, I don't disagree, and we can talk about the merits of that technical review or lack thereof, because that was challenged as well. I would suggest that we need to look beyond. I think registry data can help us to achieve that in ways that randomized controlled trials never will. When we get to a point where we can conduct a randomized controlled trial in lymphedema with 300 or 600 patients, then let's talk about going back to them with that data. The challenges of that, as many of you know as researchers, are significant. And we need to find ways to look at data differently. And the registries can help us to do that. The registries can help to collect data from disparate parties around the country and track these best practices. That's my suggestion, is moving from the RCTs of 45 patients, which are valuable, but in this patient population, think about that. Think about how many things we control out of that study to make it less meaningful and less extrapolable to our patient population. And a study with an N of 45, I mean, that's, yes, there's statistical validity in that study, but it's not enough. That's not going to get us high marks on a technical review. What we will see, though, is the use of registry data. It's going to take us time, but I would suggest we have to think differently about the data that we want and need. And I don't think it's about setting up more clinical trials in randomized controlled trials and cohort studies. I think it's encouraging our therapists in the clinician in real time, the patients that they're seeing, putting that data into registries and us utilizing that data in an analytic way to show this is really where we see. This is where we see the least amount of variation and the best possible outcome with the positive patient report as well.
I have a comment. Thank you for a very good presentation. And I think those are very important issues for us as a researcher and clinician. One thing I think is a double-edged sword for, try to promote standardized practice, what is the best practice, and then also while we also want to encourage innovations and also new treatment. I'll give you a very good example. So my daughter, who is allergic to food, so for years she went through like 300 doctors, and for eczema, listed by the food allergy. Everybody, every single doctor should went is unified standard care. Say you cannot have a bath, you cannot do this, you have to do this, you have to do that. Until we went Mount Sinai International Food Allergy Clinic, everything's revolutionized. Say you have to take a bath every day for 2 hours. You can eat everything. You don't need to do all those lotion things. You just use a coconut butter. In 1 month, she's cleared, she's fresh, and this is how she told me. She said, "Mommy, I think we waste all the monies for those bad doctors. I want to be a doctor because I think I can be better." So that is the variant. Considerably speaking, with the other 300 doctors which give standard care, but that variant actually is excellent. And so I think it's a double-edged sword. Like you try to, like for example, you try to say, we will recommend which, so for example, facts B, and that they are good instrument. The reason they have a good psychometric is because everybody is using it, and then you become a vicious cycle, So I just want to throw some stones in the water to have some thinking for that.
Excellent. That variant may be 1%. That variant is less than 1%. So we don't build practice guidelines based on that variant. We build a practice guideline based on achieving 80% of patients falling and being encompassed by that guideline. And so when we stick and adhere to a guideline, we deliver better care. We may want to think that we know better in individualizing our treatments, and data will show us that we really don't. When we follow a practice guideline, it's not 100%, and there will be outliers, but those outliers should be fewer rather than greater. We shouldn't see 40% of patients being treated as outliers. We shouldn't see that degree of variance. We shouldn't see
98% of patients, like in that situation, are treated exactly what we recommend. For example, we recommend patients, you have to be this careful, maybe wheel compression comment when you fly, and you cannot do weightlifting. Like for years, right? We have been talking to her, and that's a unified standard care. But then research kicked in, we challenged that unified care. So I think it's like I agree with you, it's the cost and what meaning.
May, there's a difference between an evidence-based standard of practice and myth that's been propagated anecdotally. I mean, the flying and not lifting and not exercising, those were never evidence-based practice guidelines. Those were myths that were propagated anecdotally from experience. So now we have data that show us here's an optimal outcome that we achieve using a practice guideline. I think we need more of that rather than the anecdotal, well, my patient developed lymphedema after starting a macrobiotic diet, so nobody should have a macrobiotic diet. Those are the things that in the past were fraught with, inadequacies in care and overutilization and constraining guidelines for patients. I think, I don't disagree with you, but I think we need more adherence to practice guidelines than less. And I think we need to do a better job of portraying that as an ALFP group and getting that out to payers, using our minimum data set to drive that. These are the factors that we want to see you capture in the clinic. That helps us to improve that standardization in practice. And not every patient will be.
I don't disagree with you, but I think we also need to promote innovation. For that. That's what I point out. So I don't disagree with you to try to get the best practice into our practice, but I think we also don't forget how to promote innovation, encourage research, and to find the best cure for our patients.
And I'm going to tell you, in my next talk, I'm going to tell you why all those tools probably won't matter in 5 years. Really? Yeah. I think Medicare's going to wipe it. They're going to tell us they want one reporting tool. They've already told us that, and we're fighting it tooth and nail. They want one reporting tool. We'll talk about that in my next talk. Jane has her thing.
Nicole, thank you for a very thought-provoking talk, and thank you for the good questions and answers. Okay, that's okay. And Nicole will come back, and with Heather joining her at the podium after your lunch break, so you'll have more information and more thought-provoking discussion, hopefully.